Now let's talk about the cervical spine in specific relation to injury and management in wilderness or austere environments. If we brush up on our anatomy, we'll recall that there are 8 cervical nerves and 7 cervical vertebrae. Going a step further, we see that the majority of those cervical nerves are involved in motion of the neck and head, as well as the upper extremity. Of note, though, we need to pay particular attention to C3, C4, and C5. If you remember the saying C3, C4, C5 keep the diaphragm alive, that's because those nerves are responsible for innervating the diaphragm and enabling us to breathe. So it makes sense that a high spinal cord injury above that level would result not only in quadriplegia, but the requirement of mechanical ventilation, whereas a lower cervical spine injury might result in paraplegia, complete paralysis of the lower extremities, but you might preserve some of your bicep and tricep motor if you have a C8 injury. You might just lose some ability to utilize your hand. So much of our use of cervical spine collars or neck immobilizers is not based on any good evidence or any good trials, but rather on the assumption that doing so will benefit the patient. You combine that assumption along with a highly litigious society, and you have the overuse of these cervical spine immobilizers. And if you've ever worked in the ER or on an EMS rig, you are quite familiar with this type. This is probably the most common type that we see. It's a rigid cervical collar. Now, what's interesting is that there is a correlation between decreased spinal cord injury over the past 3 to 4 decades in the setting of blunt trauma. Now, often this is attributed to EMS protocols, though no study can definitively find causation. Other people argue that the decrease in spinal cord injury might be related to improved automobile safety and the introduction of utilizing surgical techniques to stabilize cervical spine fractures. Now, this isn't to say that EMS protocols are not associated with this movement, but ultimately, how much do we really know about the efficacy of these devices in preventing further damage or spinal cord injury in the setting of a cervical spine fracture? For the most part, we utilize 2 decision rules in helping us decide if a patient in the emergency department requires radiography to determine if there's a cervical spine fracture or injury such as subluxation that can result in spinal cord injury. One of the most common utilized is NEXUS, that stands for National Emergency X-Radiography Utilization Study. And essentially, if all of the criteria in that box are met, then we can assume with pretty high sensitivity that there's no fracture or significant bony musculoskeletal injury, and therefore no risk of spinal cord injury from that fracture or instability. Moving on to the Canadian cervical spine rules, as you can see just off the bat, it's a little bit more complicated than the NEXUS criteria. There's more pathways, there's more things to take into consideration in regard to the mechanism of injury, the age of the patient, things along those lines. So this, in some institutions, is used less frequently than NEXUS just because it's more quote-unquote complicated. But overall, an analysis has shown that this may be more sensitive and specific than the NEXUS criteria. Either way, we have 2 pretty sensitive decision rules that we utilize in the emergency department to help us determine the risk of a patient having a cervical spine injury. Now, that's in the emergency department, so how can we actively translate that into the austere environment? Thankfully, the Wilderness Medical Society has come up with some guidelines based on evidence at hand to determine what we might be able to do in regards to managing cervical spine injuries or mitigating cervical spine injuries in the austere environment. So what we need to know is that essentially there are 5 types of patients. There's the uninjured patient, there is a stable spine injury without existing or potential neurologic compromise, and then there's the patients classified in 3, 4, and 5, as you can read here. Ultimately, our job is to try and determine if a patient falls into category 1 or 2, because those patients do not need immobilization. These are people that we can extricate without spinal immobilization. Now, this isn't to say that the people in group 2 won't have an injury, but it is likely of no acute consequence or severe potential detriment. And ultimately, we can never be 100% with any of our criteria or our rulings, but we would like to be better than 99% certain that someone is not in group 3, 4, or 5 if we're going to clear them. And so how can we determine that is what we'll spend a little bit of time talking about today. So the beginning portions of the article discuss what we need to do when we're addressing somebody that has a potential cervical spine injury. One thing is to put them in the neutral position, and we do that by applying manual cervical traction. If a person is injured and has their head turned, you would actually need to grab their head, apply a small amount of traction, and then rotate their head so that it is in anatomical alignment with the rest of the body. After doing so, you would then need to hold their head in that place, hold them in manual traction. If you're going to place a patient on the backboard, it's advised that you actually lift and slide the backboard underneath them while the person immobilizing the head is doing what's known as the trap squeeze or the trapezius squeeze. And we'll show a picture of that on the next slide. It's important to understand that immobilization may actually be detrimental. A rigid cervical collar has been shown to limit the airway, decrease a patient's forced vital capacity, and actually increase the intracranial pressure, things that can all potentially be bad for a patient. However, it is noted that we should use spinal immobilization in a patient with severe trauma or altered mentation. It is, however, contraindicated in any patients with a diagnosis of ankylosing spondylitis. In these patients, instead of using spinal immobilization, we should simply place them in a position of comfort. If you have your druthers, or you have a choice, it is advisable that you utilize a vacuum mattress as opposed to a rigid backboard. This is because it actually conforms to the patient's body and limits the amount of mobility that the patient has and provides extreme comfort towards the patient, reducing things like pressure ulcers. Ultimately, spinal immobilization is not indicated in penetrating trauma. Now, going towards the future, it's been postulated that ultimately a vacuum mattress style cervical collar might be the best thing for patients in that it can conform to the patient's own body and not limit the airway. So this is an example of the trap squeeze, where the gentleman at the top of the screen is holding the sides of the head with his forearms, and then with his hands in sort of a lobster claw formation is grabbing the patient's trapezius muscles, or the shoulders. And in doing so, it creates sort of a rigid form along the patient's head to minimize their movement. This trap squeeze should be used anytime a patient is moved at all with the risk of a cervical spine injury. So whether you're lifting and sliding to place them on a backboard or performing a log roll. A quote from the article that we're referencing today states this: in the austere environment, the goal of spinal assessment should not be to definitively rule out or recognize all forms of spine injury. Rather, the goal should be to minimize the risk of missing or exacerbating a potentially unstable spine injury. So, after doing a big literature review and doing some expert recommendations, the Wilderness Medical Society has come up with this algorithm. It basically states that if you follow it starting at the top left, a patient with blunt trauma with a mechanism suspicious for spinal trauma, if they meet any of those criteria in the second box to the right, then you would likely need to immobilize. Now, severely injured patient is defined as somebody that has abnormal vital signs, such as a systolic blood pressure less than 90 or a respiratory rate less than 10 or greater than 24. If they don't have any of those signs or the other criteria in that top right box, then you would go down to the next box in the middle right where it's commenting on significant spine pain or tenderness that the patient rates as greater than or equal to 7 out of 10. If they have either of those, then you immobilize. Moving further down, If the patient doesn't have any significant pain or tenderness greater than or equal to 7, then you will ask the patient to voluntarily flex, extend, and rotate the spine 30 degrees in each plane, regardless of their pain. If they're not able to, then you need to immobilize. If they can, then there's no need for immobilization and the patient can carry on with any sort of extrication that's planned. So earlier we were talking a little bit about cervical spine immobilization, but we're not always going to have one of these rigid cervical spine collars. So what are some ways that we might be able to improvise cervical spine immobilization or other things that might help us limit the range of motion of the cervical spine to prevent or mitigate injury? So one of the most common ones is a SAM splint. It's a commonly used device, and it actually has good instructions on how you can create this. And you'll see that pictograph there to the bottom right. Some other potential improvised medical devices for the immobilization of the spine and extrication are listed here below. You can create a C-collar using closed cell foam from the insulation padding that you would sleep on. You can use thick, bulky blankets or clothing to actually wrap around the neck and the head, taping it in place. You can create head blocks using boots of the patient or towels rolled up and taped in place. You can create a short board or a short backboard using a rucksack in which you face it down the back of the patient's spine and have the belt going over their forehead to help immobilize their head. And finally, you can create a litter using tree limbs or poles, or you can create a litter using a climbing rope. And these are all techniques which we will be practicing in the field next week, and you can reference videos online as well. Now, earlier I mentioned that going forward in the future, there might be a cervical spine collar made out of a vacuum mattress, and actually there's a company that has created one. This is called the SIP Quick, or Stabilize in Place Quick. And as you can see on the patient's right, there's a small vacuum that's there to suck out the air from this device and then create a rigid foam material that will conform to the patient's own anatomy. One final thing that I want to mention when utilizing spinal immobilization in patients, if you have an adult, the majority of adults require anywhere between 1 to 3 centimeters of occipital padding to actually raise their head and bring it into better alignment. Now remember, for pediatric patients, you actually need to often pad below the shoulders, some similar amount, usually 2 to 4 centimeters below the shoulders, to actually bring their neck and head into cervical alignment. And this is due to the disproportionate ratio of their head to their body. So just one more thing to consider if you're choosing to go forward and utilize spinal immobilization on a rigid backboard.